So my name is Nancy. I'm from Soroka. My case is also about ovarian imaging and about pelvic pain. The patient is a 58-year-old woman. She had pelvic pain. She's a smoker, but otherwise healthy. She had a history which was quite insignificant. She told us that she had trauma as a child from a bike fall and had splenectomy, but otherwise was healthy. In addition, in the early 90s, she had, again, back then was having chronic pelvic pain, so she underwent a laparotomy, and ovarian cystic aspiration revealed hemosiderin and erythrocytes, but no tumor cells. Unfortunately, I didn't have any prior imaging, but I brought this CT SurView image instead of an abdominal X-ray, and we see that there's a hint of a central abdominal mass displacing the bowel loops, and we see a staple in the left upper quadrant. Additional information, her lab studies were unremarkable, but her tumor markers showed an elevated CA125. Based on her clinical and laboratory findings, she was referred to an abdominal ultrasound. So the first question, what is the most common cause of chronic pelvic pain in women? I think we can skip it. We've talked about it a lot today. So it's endometriosis, and it also causes infertility, dysfunctional uterine bleeding, and unfortunately, this wasn't really the age group. Our patient's a bit old for active endometriosis. So the ultrasound findings, we see this large cystic central abdominal mass. And do I have a mouse here? Yeah. So with internal echoes, and as well in the pelvis, you see a probably left ovarian multicystic mass with different echogenicities of the various cysts. Just as a hint, the blue arrow is showing that the right part of the mass is more solid. So question 2, regarding the assessment of ovarian masses, all of the following ultrasound findings are suspicious for malignancy except. Okay, so of course wall irregularity, exceptations, and papillary projections are all malignant indicators, whereas a size greater than 9 centimeters is also suspicious for malignancy. CT was done, and we see here the large, again, central abdominal cystic mass, which is not quite as fluid dense as the urinary bladder. We see the red arrows pointing to this papillary projection, as well as some more thickening of the septum on the posterior wall, and some thin septations on the right lower wall. And then we also see these green arrows showing these multiple solid, hyper-intensing, round and oval peritoneal implants, which we weren't quite sure what those were. If we just look again at the lower slices on the axial CT, we see that the left ovarian mass is now more clearly defined. We see that it's, again, multicystic with different densities of different fluids. However, we see now the solid component is separate, and it's one of these peritoneal implants. It's actually the largest one, which is about 3 centimeters in diameter. So the question is, which of the following is not true regarding peritoneal implants from ovarian cancer? Okay, so the answer here is, obviously, it's that the peritoneal implants are usually hypovascular, right? They're usually not so well defined, hypovascular, cloudy sort of structures. So based on the CT findings, the patient was referred to MRI for further investigation of both the cystic and the peritoneal masses. And our main diagnostic questions were, are these cystic masses definitely ovarian in origin? Are we looking towards something more malignant or benign? Could this possibly be endometrioid tumor based on her previous suspected diagnosis of endometriosis? We really had no history. She was Ola, Dasha, and whatever. And are the multiple solid masses malignant peritoneal implants? These, excuse me, coronal T2 MRI images, again, we're seeing here a very minimal ascites, this purple arrow, and we see the hypointense on T2, these hypointense solid structures, which are indicative of fibrosis. If we look at, again, on this image, we see that there's a thick hypointense T2 wall, and we confirm that there's no fat on the fat suppressed images. We see again in the left multicystic mass the various intensities of the various cysts. both on the T1 and on the T2 images. So this would be more of a fluid density, and this would be more of a thick mucinous, or we've ruled out hemorrhage on the T1, so more of a mucinous fluid. On this dynamic phase sagittal images, I want to draw your attention to two things. One, the peritoneal implants that I marked in green. So initially on the T1, they're rather hypo intense, and then they undergo some very hyper intense, very active enhancement, and then they remain still remain quite homogeneous in the later phase after several minutes. Whereas if we just take one of these cysts as an example, it's initially very hypo-intense, and then it has some faint, gradual peripheral enhancement of its wall. So just to discuss the MRI findings and kind of bring things together, we have this hypo-intense thick wall in T2, which is suggestive of either of a hemosiderin deposit or a fibrous wall. Hypo-intense solid element, which is papillary projections, or again, a fibrous component. Different fluid intensities were leaning towards a mucinous content here. And then the hypervascular enhancement of these peritoneal implants, we were leaning towards a splenosis, but we still couldn't rule out endometriosis plaques. But again, the age wasn't appropriate for endometriosis, but maybe an endometrioid carcinoma was still being considered at this point. So question 4, based on the imaging findings, what is your preferred diagnosis? I think I'm going to jump ahead here. And so I'm going to tell you that she underwent total abdominal hysterectomy, bilateral salpingectomy, and omentectomy. And this is the mental finding on the gross pathology of the omentectomy. And you see that there was actually even more than expected. These multiple hyperemic nodules just completely gunfire spread throughout her entire omentum. And here on the right image, we see a cross-section of the largest one, which was resected from the pelvis. So based on that, would you reconsider your diagnosis? No? Okay. So it actually ended up being a borderline cystic masses, bilateral in the ovaries with mucinous features. And splenosis. And the biopsy results came back as splenic tissue consistent with splenosis, and the ovarian mucinous cystadenoma with borderline features. So just learning points, features suspicious of malignancy in ovarian tumors include wall irregularity, thick septations, papillary projections, and size greater than 9 centimeters. Mucinous ovarian tumors represent a spectrum from benign to malignant tumors. It's very often a borderline middle ground. And peritoneal metastases of ovarian carcinoma are usually hypovascular, hazy, ill-defined masses. And malignant ascites is usually much more significant. In our case, we had a minimal ascites.